thank you very much for joining us today for our session on moving beyond the March rush, so a smarter approach to long-term condition management in general practice. So today's presenter is myself, Claire Temple, and I'm joined today by Will, who is co-founder and Chief Commercial Officer for Severa. So first, just a little bit of housekeeping. So please be aware that we are recording the webinar today and your videos and microphones have just been turned off while we go through the presentation. But please pop any questions in the chat and we'll go over them in the Q&A section at the end. Also note that if you haven't registered for this session directly, so if you joined via a link that was shared by somebody else, please do make sure that we've got your email address, job title and organisation in the chat so we can make sure you're invited to the D&T network if you're not already a member, and this is where you can access the recording and other information after today. Okay, so the agenda for today, we're looking at long-term condition management. We're going to explore that. We're going to look at reducing the end-of-year pressure, improving patient experience and outcomes, and looking over some practical ideas to support, including digital tools with an overview of Severa Planner. So this session is intended to be practical and realistic for busy general practice teams. The aim is not to add more work, but to explore how practices can spread workload more effectively across the year while improving care for patients with long-term conditions. So why are we talking about long-term condition management now? So the start of the financial year often brings good intentions and plans for proactive care, but as operational pressures build and appointment demand rises, structured LTC reviews can quickly drift down the priority list. And before long, practices find themselves facing the familiar end-of-year rush to close QOF gaps, complete annual reviews, and meet contractual requirements before the end of March. However, the direction of travel across primary care is changing. So the NHS 2026-27 GP contract, the PCN DES, and the wider planning guidance are all reinforcing a stronger focus on prevention, proactive care, population health management, and neighbourhood-based working. And practices are increasingly being encouraged to move away from reactive, target-driven approaches towards a more strategic, clinically meaningful long-term condition management delivered consistently throughout the year. So we're now moving into Q2. I just wanted to pop a poll in just to see if you have an idea of where you currently are with your long-term conditions. Are they on track so far in the year? Or are you slightly behind already? It'd be interesting to see if we can get some answers on that. Okay, so it's equally spread at the moment. Yeah, so we've got a lot of people saying yes, one saying no, one not sure. So that's great, just to give us an idea of what we're working with. So as GP practices, you'll recognise most, if not all, of these challenges, and they don't exist in isolation. So that demand is rising and workforce pressures aren't easing. And at the same time, the patients coming through your doors are increasingly complex. More people are living with multiple long-term conditions, and a single condition review model simply doesn't keep pace with that. So where reviews are fragmented, patients end up attending multiple appointments across the year, which adds to your workload as much as it inconveniences them. It also makes it harder to have meaningful conversations about their overall health picture. QOF gaps are rarely a surprise in March. They've usually been building quietly over the year, but without a proactive structure in place, they can feel invisible until the final quarter when the pressure really hits. And that January to March window is the hardest possible time to be playing catch up. So you're managing winter demand, staff absence, and a surge in acute need, all while trying to close out the year on your long-term condition registers. And this is the landscape that we're working in together today, and the reason why a more proactive and structured approach to long-term condition management can make a real difference, not just for patients, but for practice sustainability. And this is what LTC management looks like in many practices today. And it's worth saying up front that the traditional approach isn't wrong, it's just incomplete at the moment. So month of birth recalls, annual review dates, QOF chasing, last minute searches, these are all recognisable. And month of birth systems in particular offer a simple admin structure, and there's nothing inherently wrong with them. The problem is when they become the primary driver of review activity, with clinical need and seasonal planning coming second. So I was just going to pop another poll in here. Just, do you use month of birth as your primary recall method at the moment? Be interesting to see that. I know a lot of practices still go on month of birth, but when recalls are shaped mainly by admin convenience or what's urgently overdue, the outcomes on the right tend to follow. So workload becomes uneven, the final quarter gets overwhelming, appointment availability tightens, and prevention opportunities get missed. And patients end up getting frustrated by multiple contacts at short notice. So the question we're exploring today is what it looks like to design a long-term condition management around clinical need rather than the calendar, and what difference that can make in practice. So I can see that everybody that's replied to the poll is currently using that month of birth as their primary method. So if the previous slides described the challenges, this one points towards a solution. So the key shift is moving from that reactive calendar-driven model to one that's planned and sustainable for both patients and staff. And this isn't about doing more. It's about doing things in a more considered order, rather than treating all LTC reviews as equal annual tasks. Practices can think more strategically about their population. So which cohorts need seasonal planning, which patients are highest risk, and where proactive intervention could prevent a deterioration or hospital admission. Combined appointments reduce patient contacts and free up capacity in the practice. Coordinated MDT working means that the right person is delivering the right review. And digital tools can support proactive outreach without adding in any admin burden. And ongoing monitoring means that QOF gaps are visible throughout the year rather than becoming a crisis in March. So this slide builds on the month of birth recalls, and it's worth repeating that they're not the enemy. They can provide a useful admin structure, but when they become the sole determinant of when a patient is reviewed, some of the clinical logic gets lost. So the examples here are useful prompts to think differently. So a respiratory patient whose birthday falls in January will, under pure month of birth model, be reviewed midwinter, exactly when they're most likely to be unwell and when your capacity is most stretched. So think about reviewing them in summer or early autumn. That means they're better prepared going into winter, and that appointment is easier for everybody to manage. The same logic applies across other cohorts. So cardiovascular patients with elevated risk may need earlier or more frequent contact than their annual review date suggests. And frail patients need proactive planning before winter hits, not a reactive response once it does. And patients, again, with poorly controlled conditions shouldn't be waiting 12 months between contacts, regardless of when their birthday falls. So the ask here is to start just thinking about long-term condition planning as a clinical and strategic exercise, not just an admin one. So who in your population needs to be seen when and why, rather than simply who is due next. Now, risk stratification can sound like something that requires sophisticated systems or additional resource, but in most practices, the data needed to do this already exists. So, clinical systems, QOF dashboards, and population health reports contain a significant amount of actionable information that often isn't being used to its full potential for its planning purposes. And the principle here is straightforward. So rather than treating every patient recall identically, use what you already know to prioritise. So those patients with poorly controlled conditions and those who are frequently attending or being admitted and those with high medication burden or rising healthcare utilisation. These are the patients where proactive intervention is most likely to make a difference and where delay carries the greatest risk. So identifying these cohorts allows practices to focus limited clinical capacity where it will have the greatest impact. And it will also help to surface that unwarranted variation. So patients who should be being seen but aren't, or who are using urgent services in ways that planned care could prevent. And this is the foundation of proactive LTC management, knowing your population well enough to make intentional decisions about who to prioritise, when, and why. So the examples here are deliberately practical. So you don't need a complex population health tool or dedicated analyst to begin. Most clinical systems and QOF dashboards already surface this information needed to identify. So like uncontrolled hypertension, worsening HbA1c, respiratory patients without recent inhaler reviews, or patients that are repeatedly using urgent appointments. So the data is there. It's about using it more intentionally for that planning. So start small. Pick one cohort and run a search, and use that to shape your recall activity for the next few months or quarter. So patients with multiple long-term conditions are a good early focus. So identifying those who could benefit from a combined review is a straightforward way to reduce appointment numbers while improving the quality of contact. And using dashboards early in the year to identify gaps rather than waiting until the final quarter gives practices time to act without the pressure. And that alone can make a meaningful difference to how March feels, or even January, February, and March. And done well, this approach supports safer, more targeted care and can actually reduce workload by focusing effort where it's most needed rather than spreading it evenly across the list. So thinking about those patients that are living with multiple conditions, attending several separate appointments across the year is often more burden than benefit. So a combined review where conditions are considered together, medication is reviewed holistically, and care is planned in a joined up way is frequently a better experience and a more clinically meaningful conversation. So this approach aligns with the wider NHS direction of travel towards neighbourhood and multidisciplinary care models, where teams work around the patient rather than individual disease areas. So combined LTC clinics, shared templates, coordinated medication reviews, and better MDT working are all practical expressions of this shift. And most practices have the building blocks already in place. So the operational case is equally strong. So fewer appointments, better continuity, and reduced admin duplication all help free up capacity that can be redirected to other patients or acute demand. But note on here that the where appropriate in the title matters. Not every patient or condition combination is suitable for a merged review, and clinical judgment should always guide that decision. But for a significant proportion of your LTC population, this is worth exploring. And effective management doesn't need to rest solely on GPs and nurses. Many practices now have got access to a much wider workforce, particularly through the R's roles. And there's a real opportunity to think more deliberately about how these roles contribute to planned LTC activity. So the move towards the proactive management creates a natural opportunity to revisit your skill mix in the practice. So when reviews are planned in advance rather than being reactive, it becomes much easier to match the right role to the right task. And clinical pharmacists and pharmacy technicians are well placed to lead on medication reviews and support patients with complex polypharmacy. HCAs can conduct measurements and data collection ahead of clinical reviews, making those appointments more efficient. Care coordinators can manage recall administration and follow-up. Social prescribers and health and well-being coaches can support patients with the wider determinants that affect how well they manage their conditions day to day. And used well, this approach allows GP time to be reserved for the most complex clinical decision making where it's genuinely needed, rather than being consumed by reviews that could safely and effectively be delivered by another member of the team. And many practices have these roles in place. The question is whether they're being fully utilised within these long-term condition pathways, or whether there might be an opportunity to be more deliberate about how they're deployed. So having the right people in the right roles is only part of the picture. So digital tools can also play a significant role in making the long-term condition management more efficient without adding to clinical workload. Technology alone is not the solution, and it works best when it sits within a well-designed pathway rather than being layered on top of a reactive one. But used well, it can meaningfully reduce the volume of face-to-face contacts needed and free up appointment capacity for patients who genuinely need it. Some messaging systems can support recall and follow-up without requiring phone calls or letters. Online questionnaires, such as Flores or similar tools, allow patients to submit review information ahead of an appointment, meaning that the clinical contact is more focused and productive. Remote monitoring can flag deterioration earlier, enabling proactive intervention rather than reactive response. And here it's worth asking whether your current digital tools are being used to their full potential within your long-term condition pathways, or whether there is capacity to extend how they're being used. So do you have Flores that cover all of the areas that you currently would like them to, or is that something you could explore a little bit more? And as practices move away from reactive end-of-year recovery work, a growing number are turning to digital planning and recall tools to help manage that LTC activity more strategically throughout the year. So these tools are relatively new to primary care, but are gaining traction both at practice level and across PCNs, precisely because they address the operational challenges we've been discussing. Rather than relying on manual searches, spreadsheets, and month of birth lists, they can give teams real visibility across their entire long-term condition population in one place. And that visibility makes a significant difference. So being able to see which patients are overdue, which conditions have the highest gap rates, and where workload is clustering earlier in the year rather than in January, changes what's possible in terms of that proactive planning. So for practices managing those multiple conditions across a complex population, these tools can also support the kind of combined review planning and coordinated recall that we talked about, reducing that duplication and spreading workload more evenly across the year. So this is an evolving area, and I'd encourage practices to explore what's available and consider how it might fit in with your existing or your changing workflows. So Severa Planner is one example of the types of recall tools practices may wish to explore. So tools like the Severa Planner are designed to give practices visibility across QOF, local and best practice targets in one place while supporting more coordinated recall workflows. So that again, rather than relying on those manual searches and spreadsheets, they help teams identify which patients require that intervention. They can track outstanding reviews and plan activity more deliberately across the year. And where appropriate, they can also support the kind of combined review planning we were discussing. So bringing multiple conditions together into fewer appointments. Importantly, these tools are not intended to replace clinical judgment or override existing practice workflows. They play a role in operation, so helping teams plan more effectively, prioritise clinical need, and spread that workload to stop that pressure hitting at the end of the year. But for practices managing growing demand alongside workforce pressures, that kind of structured planning support can make a real difference, reducing the burden of reactive recall and creating space for a more proactive, patient-centered approach. So I'm going to hand over now to Will from Severa. He's going to give an overview of how you can use Planner and how it will help in your practice.
Thanks so much, Claire. Really appreciate that. I'm just going to take the screen share now. Can everyone see that okay?
Yep.
Wonderful. I'm not usually as smiley as the headshot picture there seems to be, so I might have to change that in the future. But yeah, it's a real pleasure to speak to you all today. We're from Severa, one of the co-founders. My background was trained as a medical doctor in London, and we've been genuinely obsessed with all things long-term conditions and recalls. And it's nice to see some familiar faces in the webinar today. But my hope today is to show you what we've designed and built, which is used by practices every day at the moment, doing thousands of recalls. And it was really born out of our own learnings from delivering care to patients. So for those who don't know, we do run a virtual clinic where we manage patients on behalf of practices. We manage up to 200,000 patients at the moment, and we just found the same sort of challenges that practices are running in today. So my slightly controversial opening statement is we believe that we found a way to really fully automate the full process of recalls. And to Claire's point, it's not about replacing, it's about really augmenting what you're doing and then freeing up that capacity for others to do more things in the practice as well. So kicking off, I was asked to kind of share a case study. And so we've got a practice here in Manchester who is a 14,000 list. And I think their quote probably resonates with many people. So, you know, from using Planner, they're saying that they don't have to come in, run the searches, wait for them, and sort of wait for that to happen, and it's all done for you. And what we'll come to see as part of my segment is just how manual and hard all of those processes are. So before the world of sort of Severa, they had two staff members who shared the role of doing the recalls. It was quite complex. They had a giant spreadsheet, which got quite busy and quite messy. And it also was quite hard to monitor what was going on, because when one of them was off sick or away on annual leave, it was hard to know which patients needed chasing, which ones didn't. And then since moving to Planner, they've been able to really streamline that process to just one individual who kind of logs in once a week, selects the recalls, and then it all happens in the background. And like I said, we're moving towards a place where once you set those rules up once, it will then fully automate it for the remainder of the year. And many people on this call would be very familiar with what's on the screen here, which is this is what Asheville were using before we came into the practice. So they use Ardent as a form of sort of tracking where they're at in terms of targets. They would then run searches quite manually, and it was always the classic EMIS takes forever to load. So we'll run a search, go make a cup of tea, and then come back, or maybe not in this weather, but it would usually take a few minutes. And then, like I said, there was that kind of giant color-coded spreadsheet where it had so many different variables of conditions and meds monitoring. And then last but not least, they would use an SMS tool like a Florey, and they were batch messaging patients, and they were starting to find that patients were not engaging as much as they previously would. They were just getting overwhelmed and bombarded with messages. and patients who had multiple conditions were getting sent multiple things. And we really empathize with that, and we wanted to kind of explore exactly why it's so hard for practices to do this today. And so this was like an example that I wanted to visualize. So this is like a practice list that you tend to see. Obviously, you'd have a lot more patients in this, but just an example of this is your cohort spread. Some patients will be on the QOF target for cardiovascular disease. There will be some patients who are on an overlap for sort of respiratory disease. And then you add on another dimension as well, which is don't forget about meds monitoring. So that same patient who's got cardiovascular disease, who's quite complex and has COPD because they're a long-term smoker, may also have a high-risk drug like methotrexate, which needs monitoring. And all of a sudden, you've taken something that is one-dimensional into something that can be sort of two or even three-dimensional. And that's why running lists can be so hard and so complex. And this is a stat that we pulled from all of the practices that we have currently using the planner. So on average size, believe it or not, 12% of your total patient register. So if you're an average size about 9,500, there's about 1,200 patients who have 2 or more long-term conditions. And what that signifies is that they'll be on multiple medications, on multiple registers, and the kind of the coordination is really, really complicated. And don't forget, the rules are extremely vast and dynamic. So I wanted to give you a sneak peek of what we've kind of built as our rules. And I don't want to overwhelm you, but this is more just to empathize and say, I don't think it's humanly possible to actually look at all this in one go. So on the left-hand side, just in alphabetical order, which it doesn't fit in the one screen, is all the different long-term conditions, both QOF and non-QOF, that you need to be looking at for a patient. And you can see here that the rules vary. Some need 12 months, some need 6 months, some need certain blood tests. And so patients fall into multiple categories. But on the other hand, practices also get penalized for not doing their CQC drugs monitoring. And this is exactly what CQC pick up on if you're not following up the patients. And so you can see here, some patients need a thyroid function test every 3 months, some need every 6 months. And the rules are endless. And without a clear, structured way of viewing all of this, what tends to happen is duplication. So a patient will come in for a blood test on one day, and then you'll find that actually they need to come in a few days later. And what we tend to find actually from our experience is that GP partners tend to be more acutely aware of this because they're, the most incentivized to reduce duplication. So they'll keep an eye on whether or not they can combine things. But as we all know, the partners aren't usually the ones doing the recall or the planning. It tends to be the practice management team, the operational teams, and the recall teams who may not have as broad as a clinical picture. And so how do you assist them to make sure they're doing all things as effectively as possible? And that's where we believe having technology can help. And so here's a way to kind of visualize what practices are doing today in terms of multiple recalls and how we can go into a more patient level view. So as I mentioned before, you've got all of these different targets, you've got all these different drugs monitoring. What you're tending to do right now is running sort of the atrial fibrillation recall list, the asthma recall list, the renal function list, the thyroid list, and the patients are sitting on all of them. What we want to be doing is actually seeing the patient as a whole. So seeing what things are due, both in terms of targets and investigations in one go, so you can do it all in one single recall. And so here you can see a patient sitting across all of them. And what we really believe is all of these manual steps are taking quite a bit of time. It is doable, and most practices will happily say they are able to manage, but what is it costing you in terms of time? You may be a practice that is well performing in terms of QOF, but are you doing it all at the end of the year? How many appointments is it taking you? Or could you be doing it more effectively with those allied health professionals that Claire mentioned before? And one thing we wanted to really address is this idea of the month of births versus the risk stratification. And again, been absolutely obsessed with this kind of idea of why months of birth is so useful pre-technology, which is if you were to run a search on any one condition, you'll always miss something else. So if you only look at it through the lens of cardiovascular disease, you'll end up missing things for respiratory and others. So month of birth was always a good catch-all way of kind of doing it over 12 months. And I promise you, it's not just because I'm a March baby that I'm biased against it, but I think that the only way we can move towards a genuine high-risk population health model is by seeing patients as a whole. And so hopefully you can see here what we've designed to help you with this So I'm going to give you a very quick whistle-stop tour of some of the features. It won't be a full demo. If you'd like to have a demo, then you're more than welcome to book a time with us on our website. We'll send you the link afterwards, but I'm just going to give you the quick features that we've really transformed the way we do our recalls. So this is the first view. So this is fully integrated with both EMIS and System 1. And what you're seeing on the screen here is a way which you never have to run a search again. You'll see all your patients here being pulled in. You can filter it by target areas. You can also filter it by months of birth if you'd like. But the key thing is you can filter it and sort it by high risk to lowest risk. And the benefit of doing that is I'm going to pause on the screen in a moment, but this patient here, Felix Carter, you'll be able to see what he's due for his blood pressure, what he's due for his blood tests, foot checks, and also lifestyles, and also what reviews he needs. So suddenly you're being able to risk stratify, but actually cover every single parameter. And every single tile here is powered by every single rule that I showed you on that other screen where you had the whole list of 3, 6, 12 months. So as soon as something is due for a patient, it will be flagged here. The next thing that we designed was, well, how do you make sure that you actually really efficiently allocate slot types to the right clinician and patient? So what do I mean by that? Well, if you've got a nurse who's a specialist in asthma, well, then she should be seeing, or he or she should be seeing the asthma patients. But if you've got a patient who's got 3 or 4 different long-term conditions, they should be booked in with a clinician who's competent and wants to see all of those conditions. And so suddenly you can really route the patients to the right place. And we do this by setting up booking links with you. So when we onboard with you with the practice, we'll ask you which slot type goes to who, and then we intelligently match those slots. And so as Claire mentioned before, what it leaves is that the more complex patients the GPs can manage, and you really start to drive efficiency across all of your different patients. But then here's where it gets really, really powerful, and no tool at the moment on the market does this, which is how do you do things in bulk? So you're not having to spend hours and hours doing searches and recalls. You're doing it all in bulk, but actually every patient gets their own personalized journey. So what I mean by that is if you're using tools like AccuRx or Florys, the likelihood is you're sending out mass questionnaires. So, blood pressure questionnaires to your whole hypertension register, and then maybe a week later, the asthma questionnaires, and patients are getting quite bombarded. What we've designed is basically a flow whereby every single patient gets the relevant next step for them in bulk. So what you're seeing on a screen is a patient may need a blood test first, so they get asked to book a blood test. A patient may need a questionnaire, and then we've built every single questionnaire into there. So you can do it all in bulk, but everyone gets their own bespoke journey. And just so you're aware, all these messages are saved back into your notes. It sends as your sender ID from the practice, so there's no difference to if you're sending out an AccuRx. And the moment the message goes out from here, because it's saved in the notes, if they do decide to pick up the phone and ring your reception, they'll be able to answer the patient's queries as soon as possible. So this is what it looks like from the patient side. It's a simple text message. They log into a web application with their first name and surname, similar to the NHS app where they don't have to download anything. And then the beauty here, again, I'm always very excited about this, is every single questionnaire is available here. So I'm going to pause the screen. So you've got your asthma questionnaire, you've got your blood pressure questionnaire, you've got your lifestyle. All of this is pulled from the codes in the notes. And so this is dynamic for the patient. And so suddenly a patient who's receiving sort of 10 or more messages sometimes in a year is getting just a really, really targeted, personalized message, and you're going to increase engagement as a result. And we've even built in feedback loops. So going back to the example of Asheville, one of their biggest problems was when one of them was off sick or on leave, they didn't know who needed chasing and who didn't respond to the first message. What Planner automatically does is if a patient responds to the booking links, it automatically doesn't send out a follow-up. But if they haven't responded to the links or booked in a slot, 7 days later, they'll get the reminder follow-up. And the reason it's 7 days is so that everything can be invite coded and used for your PCA and exception reporting at the end of the year. But this is where intelligence and automation can really benefit a practice. And I've saved the kind of the best till last, but the thing that we were really excited about as well is in order to complete the full loop, blood tests are a huge aspect of it. So we've been able to integrate with ICE and TQuest and actually request the blood forms on your behalf and actually save them into your notes as well. And the huge time saver is twofold. One, you're not having to actually open it up and click through it, which is those who have done it themselves know it takes several minutes. But the other thing is that actually your non-clinical staff, as I said before, won't get these things wrong now. So it will actually recall and click all the relevant bloods that are recommended based on the rules on the previous screens. And so gone are the days where you'll be double booking people and sort of requesting bloods multiple times. You can do it all in one single sitting. And we've even designed the ability to actually proactively include bloods. So if you've got a patient who's actually due for a bloods tomorrow, but you can see, and the software picks up that they are also due for a bloods in 3 weeks' time, it will actually automatically request those bloods just to save that patient another visit, another blood test, and saving the NHS some more resources. So we can really see how this compounds across the board. And so I'll just finish here and say we really wanted to look at the healthcare system as a whole and say, well, what are the biggest challenges we're facing? And the biggest challenges is productivity, because unfortunately, we don't think there's going to be a lot of new money coming down the track from new government. Even with the change towards neighbourhoods, I think we're going to have to do more with the same team. And so wouldn't it be really magical if we could just really take some of this non-clinical administrative burden and combine it all into one intelligent automation? So on the screen here, you can see the full setup that practices are doing today. So you bulk select, it automatically generates the next step for every patient with every single bespoke message. In the background, it will automatically match the patient to the right booking slots for them to book into. The questionnaires will go out for the patient, the blood forms will be generated, and then the patients will be booked straight into the appointments with all of the notes coded back in seamlessly. So that's it. That's what we've been designing. We'd be delighted to speak more about it, but yeah, you can tell we're really passionate about this and we really want to help practices save time on this. Thank you.
Thank you so much, Will. That's really, really helpful, and I hope everyone can see the benefits of that from what we've been talking about today. I've just got a few slides to finish off, and then we'll get to some questions if you've got any questions that you'd like to ask Will. So before we look at sort of what good could look like, it's just worth pausing on a few questions here that might help you identify where to focus first. So these aren't exhaustive, they're just prompts for an honest internal conversation about where current processes are working and where there might be room to improve. So which practice cohorts are creating the most operational pressure? Are reviews happening at the right clinical time or simply when their admin is due? Or where is duplication sitting in your current model, and is your existing workforce being used to its potential? So like I said, it's not an over exhausted list here, but it does open up the conversation so that you can surface your practice priorities with your team. So just looking through that and thinking about what we've spoken about today, I'd be really interested to know if you're going to look at any of these ideas, which areas would you consider looking into after everything we've been through today, just to get a few ideas of what's kind of piqued your interest. While you're doing that, we'll look on to what good could look like by March. So if practices begin making even some of the changes that we discussed today, the cumulative effect by next March could be significant. So not a perfect system, but a noticeably different one. That less end of year pressure, more evenly spread workload, QOF performance building naturally across the year rather than being chased in the final quarter. Earlier intervention, meaning that you're going to avoid exacerbations and have better outcomes for patients. Staff experience will be more manageable for the demand, and patient experience will be better. It'll be, you'll introduce that continuity and coordination. So these outcomes are realistic and achievable through incremental change. They don't require large-scale transformation. So before I move on, just going to see what kind of words we've got. Okay, so recall, immunizations, severe, high risk recall. That's really good. So yeah, just to bring today's session together. So prevention and proactive care are increasingly central to how primary care is expected to operate. And LTC management is a key part of that shift. So the month of birth recalls have their place, but they should support LTC planning rather than drive it. Strategic year-round thinking, using the data you already have, deploying your workforce more deliberately, and combining reviews where appropriate can meaningfully reduce operational pressure while improving the experience for patients and staff alike. Again, that risk stratification doesn't need to be complex to be effective, and those small changes consistently applied can make a big difference. But really, the starting point is simply deciding where to begin. So, as I said, there was a question in the Q&A. All of the resources and information from this webinar will be available in the D&T network. So you can join the network by scanning the QR code on the screen, but in the email you'll be sent after today, you'll also be invited to join. And as a nice little bonus for everybody that's joined us today, Severa are offering an exclusive 5% discount for you for Planner. So it's well worth looking into. I want to say a huge thank you to Will for joining us, and thank you very much. And I hope you all keep cool over the next few days. All right, lovely. Thank you very much for joining.
Thank you. Stay cool.